Here we are with chapter 29. In this chapter, we're going to talk about psychiatric emergencies. It's important to understand that the mind and body are integral components of being a complete human being. It's all tied together. It all meshes together. So an illness can impact a person's behavior, which can often lead to anxiety or depression, as well as changes in mental state can affect both physical health and mental health. So individuals with depression may actually experience loss of appetite, or increased susceptibility to physical illnesses. So when we're examining these patients, our aim is to try to both understand the physical and mental factors that may be contributing to what's going on with this patient. Most experts define behavior as the way an individual acts or performs. Behavior is going to encompass those things like all of the actions people take and the reasons behind those actions. Overt behavior is visible and generally understood by those around that individual. However, covert behaviors may have hidden meanings or intentions that maybe only the individual themselves actually comprehend. Nearly all disordered behavior reflects the person's attempt to adapt to stress. Behavioral emergencies essentially are situations where the patient presents with an issue that involves a disorder or mood, maybe a thought or behavior that disrupts activities of their daily living. A psychiatric emergency, on the other hand, is an abnormal behavior that poses a threat to the health or safety of the individual or others around them. So it's important to understand the difference between the two, between a behavioral emergency and a psychiatric emergency. A behavioral emergency is going to really kind of mainly affect that one person, kind of disrupt their mood and thought and behaviors, whereas a psychiatric emergency it's going to pose a serious threat either to that individual or those around them. The operative definition of behavioral or psychiatric emergency is often determined by the individual who calls 911. This can be challenging to assess when trying to understand the patient's confused or distressed emotion, so it can be difficult. According to the Centers for Disease Control and Prevention, the average number of mentally unhealthy days reported by Americans has increased. The Office of Disease Prevention and Health Promotion estimates that 43.5 million adults aged 18 or older experience medical or mental illness over the past year. And the National Institute on Drug Abuse reports that 7.7 million U.S. adults have both mental illness and a substance abuse disorder, complicating their assessment and treatment options. Communicating clearly can be difficult when a patient's thoughts or behaviors are really erratic. So plan to spend a little bit of extra time with them in order to figure out what's going on. Always try to obtain consent whenever possible. If the patient is unwilling to engage, keep talking and explaining what your role is. If the patient refuses transport, of course, you're going to have to follow local protocols and possibly even involve law enforcement whenever indicated. Make sure that you clearly explain any treatments or medications. Never assume the patient understands what it is that you're telling them, so you need to be very clear on what you're doing. Document thoroughly using objective and factual language, and include any relevant statements that are made by the patient. Abnormal behavior is usually caused by a mix of biological, psychological, and social factors. It can stem from underlying medical conditions or even brain disorders. Developmental challenges and early life experiences may actually further influence this behavior. Psychological stress and strong emotions can trigger unusual actions or reactions. And of course, cultural and social pressures often play a role in shaping how a person behaves. These causes generally fall into four main categories. It could be a biological or organic issue, such as a brain injury or a genetic condition. Could be environmental factors, including stressors and maybe even trauma. Could be acute injuries or illnesses that suddenly affects the brain and body. Or of course it can be substance related, like alcohol or drug use or even withdrawal. Many patients presenting with psychiatric symptoms are influenced by biological or organic factors that disrupt normal cerebral function. Such patients were historically referred to as having organic brain syndrome. The term encompasses disorders stemming from organic or physiological causes as opposed to purely psychiatric ones. For examples of specific disease states that may produce psychotic symptoms, you can take a look at Table 2 in Chapter 29, and that'll give you a few more clues to that. These conditions can actually alter the brain's normal function and lead to these psychiatric symptoms. We might have some environmental causes as well, which may include both psychosocial and sociocultural influences. Prolonged exposures to stress or stressful psychosocial events or developmental factors can lead to abnormal reactions. Socioculture factors directly impact biology, behavior, and responses to the stress associated with emergencies. Acute illness can overwhelm an individual, resulting in changes in behavior. For examples of some of these conditions that may lead to abnormal behaviors, I'll refer you back to Table 29.2. An acutely traumatic situation induces stress for the individual and those around them. And so post-traumatic stress disorder is a severe form of anxiety that arises from an overall traumatic experience. Post-traumatic stress disorder can be triggered by military combat, terrorist attacks, car accidents, and even domestic abuse or sexual assaults can cause a person to have post-traumatic stress disorder. So this here's an example of something that can trigger a post-traumatic stress disorder event. Something such as a fatal car crash or an accident that involves maybe a young child or something along those lines could not only impact, the parent in driving the car, but the other driver or the other people involved, bystanders that witnessed it, and even the medics and firefighters and police officers that responded to it. And this table here shows some disease states. This is that Table 29.2 that I was talking about. Some disease states that may produce some psychiatric symptoms or psychotic symptoms. So some of these different disease states can actually result in some of these symptoms, some of these behavioral symptoms that we've talked about. Substance-related disorders include the use of alcohol, tobacco, illicit drugs, and other addictive substances. These disorders are now actually recognized as complex biological and psychological conditions, and not just simply a matter of poor character or not having enough willpower. When a person's mental health is disrupted, the mind activates these coping mechanisms in order to try to regain that balance that the body so badly wants. Unfortunately, these efforts often show up as psychiatric signs, symptoms, or even behaviors that indicate that there's a struggle going on in order to return to that stable mental state. When evaluating a disturbed patient, you become the primary diagnostic tool through observation and interaction. So you're going to be the main tool that's trying to figure out what's going on. Assessing a patient in a behavioral emergency is not just diagnostic. It's also a critical part of the overall treatment. So as you're working your way through those questions, trying to figure out what's going on, your behavior, your demeanor, the way that you act, the things that you say can also affect and have an impact on the overall treatment of that patient hours, days, and weeks down the road. So you need to be cautious, and you need to be thinking of that along the way. Of course, when we're sizing up the scene, we always want to make sure we prioritize our own safety and the safety of everybody else on the scene, up to and including the patient. Look around the environment for any clues that might explain the patient's behavior or condition. And then, of course, think about whether the situation stems from an injury or whether it's a medical or psychological illness. Try to pin down what exactly is going on. So this table shows some safety guidelines for behavioral emergencies. Of course, we're going to make sure the scene is safe. A couple of highlights in this that might be a little different than our typical way that we have on a scene is one of the big ways is we need to be prepared to spend a little extra time there, and we need to have an action plan for if things start to go south or if we need to restrain the patient, and then how we're going to implement that. So that's why oftentimes we have to spend a little extra time. Always make sure you know where the exits are, because while the scene may appear safe initially, sometimes these patients can turn on a dime and things can go south in a hurry. So always, no matter how loud, boisterous, upset, angry, whatever the patient acts or behaves, you need to make sure that you remain calm and relaxed and not get too wound up, because if you do, they will feed off of that. Always be honest, and I know that sounds, should kind of go without saying, but sometimes we might be a little less than honest, or we might have the inclination to be a little less than honest with behavioral patients, because they're like, I don't want to get put back in the psychiatric hospital. I don't want to, whatever. And our inclination might be to say, oh, well, we're not going to do that. When the truth is, that may actually be what happens. So we need to be honest with them and say something along the lines of, maybe that's the best place. Maybe that's where you can get the help you need, that kind of thing. Or maybe we can find a different hospital than the last one you were in if you didn't like that one. So it's important to kind of be that way, and also be non-judgmental. Sometimes that's difficult. We as medics have a tendency to get a little jaded, but it's really important to be non-judgmental. Just kind of try to get them to the best place that they can be in the shortest amount of time with the least amount of judgment is the ideal thing to do. So introduce yourself clearly in order to help build trust with the patient. Form an initial impression by observing the patient's appearance, behavior, and responsiveness. Check for pupil size, equality, and reactivity. Remember, we're looking to see if there's any extracurricular substances on board. Ensure the airway is clear. Assess breathing quality and rate. Evaluate circulation by checking for, the skin signs, pulse, and of course, we're going to look for signs of bleeding if that's a concern. Decide if early rapid transport is needed based on your findings, or if you're going to have to spend a little bit of time here further assessing the situation and kind of getting things ready to get moving towards the hospital. So when we're taking a history, the mental status exam is a crucial component of the assessment for a patient undergoing a psychiatric emergency. In order to make sure we evaluate each of the systems and the function of each, we want to use this mnemonic framework called cost map. And this is what this looks like, this cost map mnemonic. So cost map is an acronym used in mental status examinations to help assess the various aspects of a patient's mental function. So we're going to look at their cognition. We're going to evaluate the patient's thoughts, processes, attention, and memory, cognition or consciousness. Orientation, we're going to see how we're going to assess their awareness of time, place, and person. We're going to look at their affect, which is going to observe the patient's emotional response and mood. Speech is going to analyze the rate, volume, and coherence of speech. Their thought process is going to look at the organization and flow of their thoughts. And then we'll test their memory. We'll do a short-term and a long-term memory test and see how well they do with that. We'll give them a word to remember and then see if they remember that. Appearance, we're going to pay attention to the patient's physical appearance and their hygiene. And of course, the last one is perception. We're going to evaluate their sensory perceptions, including hallucinations or delusions that they may be having. Those kinds of things are all noteworthy. This is a really good way for us to document their mental status and make sure that we hit all of those important points that's going to give a better picture of what's going on with them, and may help to make a determination of whether it's a medical, a drug related, or just purely a psychotic episode. Get a good set of vital signs, and of course look for signs of fever or increased intracranial pressure. We want to look at those things because those could be factors. Again, we're trying to rule out medical versus other causes. Examine the skin temperature and moisture. Inspect the head for evidence of trauma. Head injuries have a tendency to cause mental breaks. Check for pupil size, equality, reaction to light. If we have unequal pupils, it might be an indication of some sort of brain injury. So, and also note unusual odors to the patient's breath. And be sure to examine the extremities. We might be looking for track marks or, wounds or injuries or those types of things. Conduct a routine transport. Of course, this is a good opportunity to further explore the patient's mental status or to reaffirm some of the things that you've already found, during our reassessment, while we're transporting them. Monitor the patient for sudden changes in thought or behavior to see, are they kind of sticking with where they were, or is things changing and are they getting better or worse? Provide a radio report to the medical facility. This is one area where I might caution you when you're doing this. There are instances where it may be better to have your partner, if they can, that's driving you in, contact the medical facility. Remember, this patient's going to overhear everything that you're saying. So when you try to give the medical facility a heads up that you're coming, if they're somewhat unstable and they hear you say you're bringing in a psychiatric or psychotic emergency, that might not set well with the patient. So be cautious in your radio report and what your patient can overhear. Discuss with the medical facility the need for restraints or medications before implementing those interventions. So clearly we're going to reach out to medical control. We'll talk about a little bit more about restraints and that kind of thing. But whenever we're going to involve restraints, we should involve medical control and more than likely law enforcement, because, we don't have the legal right to imprison somebody or restrain somebody. So law enforcement almost always needs to be involved in those incidents as well. So if there is a medical need, we want to make sure that we meet those medical needs. We provide medical treatment before we get too deep in the weeds on the behavioral issues that are going on. So rule out and treat any medical causes, give them oxygen, test for blood glucose, administer dextrose as needed, and of course implement those general interventions for hypothermia and shock, those kinds of things. Let's treat the medical issues first before we start digging too deeply into the behavioral issues that we may be dealing with. Most diagnostic information is gathered through conversation with the patient, so it's really, really helpful to establish some ground rules for your interview. Make sure that you inform the patient about what you expect and what they can expect from you. Yes, this is different from what we do with our typical patient, but it's really important that we build that rapport with these patients so they're more willing to open up and talk to you about it if they understand what it is that your goals are, what your plans are, and they understand that you're not against them, that you're for them. Allow the patients to share their story in their own way. Ideally, you should start with open-ended questions and let the patient express themselves. Listen actively and demonstrate that you're engaged, that you're listening, you're focused on them, you're listening to what they're talking about. Don't be afraid of pauses in conversations, because sometimes patients may need the opportunity to gather their thoughts, their emotions, and think for a minute. Allow that dead space to just happen. Acknowledge and label the patient's feelings. And then, of course, avoid arguing with the patient. You want to try to facilitate open communication, direct the patient's attention as needed, and then ask those clarifying questions. And then you're going to continuously adjust your approach based on the patient's responses. Remember, don't be dishonest with your patient. You should be honest with them, because if they catch you in a lie, they're going to think everything that you've communicated with them is a lie. Whenever these situations reach a crisis level, it's really important for us to remain as calm and direct as possible. We want to try to exclude any disruptive individuals from the situation, so we may have to actually clear the room, get other people out of the room that are perhaps less understanding or just more frustrated with the situation. And then if you can, take a seat to create a more relaxed environment. So that way the patient may communicate with you more easily. Try your best, and it's essential that you show a non-judgmental attitude. It's easy to be real judgy. It's a little more difficult to show that you're non-judgmental. Put all those personal thoughts and feelings aside. Focus on the patient and be as non-judgmental. Always provide honest and calming reassurance. So be reassuring. Create and communicate a clear action plan. Let them know what it is that we're going to do, what you want to do, what the next steps are. Encourage the patient to engage in light physical activity if it's safe. Maybe do a jumping jack or two or something like that to kind of clear their mind or get their thoughts off of whatever it is that's the prevailing thing in their mind. Remain with the patient at all times for safety and support. Don't leave them alone. Ensure all the patient's medications are brought to the hospital with you. And never assume communication is impossible. Always make an effort to connect with that patient, because you just never know in what ways you might be able to get through to them. So sometimes with these patients, and it doesn't happen real often, but from time to time it does happen that we need to restrain a patient. Restraint devices can actually be improvised from materials available in the ambulance, or they can be commercially made, or a combination of the two. Whatever you're going to use, especially if it's commercially made, make sure you're familiar with how to use them and its appropriate use by your agency. Make sure before you start down this road that you have a sufficient number of personnel to restrain the patient before you get started. You should at minimum have 5 trained individuals, and make sure these are emergency personnel, not family members. You want to make sure you have emergency personnel trained for this, because family members can either get too aggressive or they may bail on you. Discuss the plan before you proceed. Gather up, talk about how you're going to do this. Law enforcement, of course, should be involved when we're restraining violent patients. But we also want to use the minimum amount of force necessary, and be cautious of how you approach the patient. Don't just rush in on them. You want to slowly work your way in there. If this show of force doesn't calm the patient down, then the responders may have to act quickly to restrain them. Remove any jewelry from yourself that could be used as a weapon, and ensure that adequate restraining devices are immediately available. Have them things ready to go. Don't go, oh, hey, run out to the truck and grab me this. That's not a good position to be in. The best position to secure a patient is to secure him supine. Secure both arms and legs on either side of the stretcher, and then turn the patient's head to the side to prevent aspiration in case there's the risk of vomiting. Never place your patient face down. Throughout the process, you or your partner should maintain communication with the patient. Treat the patient with dignity and respect at all times, regardless. Don't let them get you angry or frustrated. Remember, you're there to help. And of course, then once those restraints are in place, don't remove them. Don't negotiate with them. Don't make deals. Don't let them talk you out of those restraints. Be honest with them about the fact that you're not taking them off. They need to understand that you're going to be very clear that you're not taking them off. And then once they're restrained, you need to make sure that you continuously monitor that patient, check for peripheral circulation so that, if we've got their arms and legs tied down, make sure we still have good pulses there, monitor their breathing and all of those types of things, all of those vital things to make sure that everything is working the way that it should. Be very wary of a combative patient that suddenly becomes calm and cooperative. Odds are they're plotting something. And of course, along the way, you want to make sure that you document everything thoroughly and carefully. You may use reasonable force to defend yourself against attack, but realize it needs to be reasonable force to defend yourself. Of course, there is a proper way of using the 4-point physical restraint technique. Skill Drill 29.1 kind of covers that. So if you'll refer to that in your book, it kind of shows you how to do that properly. There's a 2-point restraint technique that is an option as well. Of course, that's going to depend on whether that's permitted by your local protocol or not. Chemical restraint's another viable alternative to physical restraint. These are a little trickier. It utilizes medication to subdue the patient, and it's going to require approval from medical control and more than likely still involving law enforcement. It's not always easier than physical restraints, and it comes with its own set of risks, because now instead of tying somebody down and restraining them, now you're going to have to probably tie them down, restrain them, and start an IV. So chemical restraint's not always a great alternative, but sometimes it's what we have to do because they just won't calm down. Medications that we commonly use are going to be benzos, antipsychotic medications, and believe it or not, antihistamines make the list because they are very effective. Common examples of benzodiazepines include things like Valium, Ativan, Versed. These medications can be administered as either intramuscular or intravenous. However, we should only administer Ativan or Versed IM because they are really the only ones that have a really reliable absorption rate. The most common adverse effects that we see with these are drowsiness, decreased mental alertness, sedation, and maybe some ataxia. These medications are generally considered safer and more effective form of chemical restraint compared to some of the other medications. They seem to work very well. They may be given intranasally if a short-acting effect is needed, and the onset of action varies depending on the route that we give them. So if we're able to give it intranasally, we'll at least be able to sedate them for maybe long enough that we can get them physically restrained to get an IV started, and then give them more chemical restraint if needed. It's a very effective means. Some common examples of antipsychotic medications are droperidol, Halidol, and ziprasidone. These are just 3 of the examples that can be used, for chemical restraints. There is a black box warning for droperidol due to its association with prolonged QT syndrome. And of course, high doses and IV administration of Halidol are associated with an increased QT prolongation and the risk of torsades. So they don't come without some risks. More than likely, you're not going to have any of these on the truck anyway. You're more likely to have one of those benzos that was mentioned in the previous slide that have come with less issues. Typical of antipsychotic medications is that they may cause seizures and a wide array of those extrapyramidal symptoms. Newer atypical antipsychotics such as Zyprexa tend to have fewer extrapyramidal symptoms and possibly even a lower incidence of some of those anticholinergic effects that come along with those. CNS depression can be worsened by the combined use of alcohol and other central nervous system depressants. So a complete history is essential before administering these types of medications because the combined effect may actually cause things to get a whole lot worse. Of course, after administering any of these antipsychotic medications, we need to continuously monitor the patient for signs of hypotension, bradycardia, and we should also watch their blood glucose levels. Antihistamines, it's another one of those that's relatively safe and yet pretty effective. And the one that mainly comes up in this one is going to be Benadryl. It's been used for a number of years in the treatment for antipsychotic or psychiatric patients. It's best known for its sedative properties when used like this, but they also produce an anticholinergic effect that influences neurotransmitters in the brain, thus affecting some of the behavior. So it's kind of a twofold effect. Can be used in both adult and pediatric patients, and there's really very low risk of any issues with administering Benadryl. So it could be possible that even a combination of Benadryl and a benzodiazepine, may be needed or may be called for. Okay, so that is part 1 of 2 for chapter 29. We'll be back and we'll talk about some more specific issues in the next section of chapter 29. See you back in a bit.